everyone. So I'm just going to quickly go over the physiology of the female pelvis. I really want you guys to pay attention to the labs and what's happening during each phase, because these are really good board questions that they are likely to ask you. So they might say, what is happening with luteinizing hormone during ovulation. So just make sure that you fully understand each one of these. So we're going to get started with labs. There are about 7 main labs that we're going to look at. And I'm just going to kind of go through them in this list order so you guys can follow along. So the first one that we're going to look at is follicle stimulating hormone. And its name is kind of what it does, right? So there are follicles inside of the ovaries that will eventually ovulate. And this hormone stimulates them to grow and get bigger so that they can eventually break open and release that egg. So follicle stimulating hormone is actually secreted by the pituitary gland, not the ovaries themselves. The pituitary gland actually sits up in the brain. In order for follicle stimulating hormone to know it is time to be secreted, it needs another hormone, a sister hormone you can say, and that is follicle stimulating release factor. Now, follicle stimulating release factor is actually formed in the hypothalamus and is active before you ever even hit puberty. And what it does is it takes that hormone within the hypothalamus and will send it into the bloodstream, where it will travel to the pituitary gland. And then once the pituitary gland receives it, it says, oh great, it's time for puberty. We're going to go ahead and release this follicle stimulating hormone. Now you have follicles on your ovaries. The next one is luteinizing hormone. Now, luteinizing hormone is in both males and female and is a necessity for reproduction. But we're talking about the female pelvis, so we're going to stick strictly to that right now. Luteinizing hormone, once those follicles have been stimulated to grow, there will be an increase in luteinizing hormone. Once that luteinizing hormone is released, it will actually cause the ovary cyst to rupture, causing ovulation. Again, it is secreted by the pituitary gland and needs a backup. So we have luteinizing hormone releasing factor that is produced in the hypothalamus and is present before puberty, but it will send those hormones off, activate the pituitary gland to release that luteinizing hormone. So kind of remembering those 4, so follicle stimulating hormone and luteinizing hormone are both secreted in the pituitary gland. The follicle stimulating release factor and the luteinizing hormone release factor are both produced in the hypothalamus. So they kind of all go hand in hand. They all have something to do with the release of the egg from the ovary. All right, moving in, we have progesterone. So progesterone is produced in the adrenal glands and as well as the corpus luteal cyst after ovulation and the placenta of a forming fetus. So if it's in the corpus luteum, which happens after ovulation, and in the placenta, we can assume that during pregnancy, it is going to increase. Progesterone's main job is to thicken the endometrium to create a comfy, cushiony bed for an ovum to fall onto and to implant and to grow without detaching. So that is progesterone. The other one is estrogen. Now this is super common with like a common lab. We've probably all heard it at some point. We know that girls have a lot of estrogen. Oh, that's just the estrogen, right? But what exactly is estrogen? And it truly is the primary female sex hormone, right? It's going to promote all of the things that are common among females. So, they're going to have a lower muscle mass. They're going to develop larger breasts. They're going to develop wider hips. The uterus is going to grow. Remember, we talked about the uterus, and in a prepubescent, the the cervix is actually bigger. And then once we get postmenopausal, when we're not releasing that estrogen, they're about the same size. So that estrogen causes that uterus to grow bigger so that eventually it can house a baby in there. The other one is estradiol. So this is actually something that we use it's a lab we use to check how well the ovaries are functioning. And in a female patient, we expect that estradiol will be elevated. So there are your labs. As we go through this, we're going to be bringing back these labs. So this is not the last time we're going to hear about these labs. You're not going to have to memorize all of the definitions or whatever and move on. You're actually going to have to know where they increase, where they decrease, if luteinizing hormone is increased, what part of the endometrial cycle we're in. So just as we go through, pay attention to these 7 labs and what they're doing during our phases of the menstrual cycle. So now that we know the labs, let's look at the stages of puberty. So puberty is kind of when we start developing those sex characteristics, and for females, it would mean that they start ovulating and having a menstrual cycle. So there are 3 main phases that we learn about. We have our premenarche, our menarche, and our postmenopause. So starting with premenarche, this is any time before the onset of the first menstrual cycle. So if a girl has not had her first menstrual cycle or her first period yet, she is in this premenarche. Now, there are 2 different types of what we call precocious puberty, where they will develop these sex characteristics and even have their period before the age of 10, and that would be considered precocious puberty, so or the early development of puberty. When we see girls that are having pubic hair before the age of 7, breasts before the age of 7, or menstruating before the age of 10, we are concerned for some type of adrenal hypothalamus gonad neoplasm. Okay, so that's the concern there when we're seeing that something is producing that estrogen and we're trying to figure out what. The other one is precocious pseudopuberty, which is just breasts. So they're not having a menstruation, but they have early breast development. And this can be due to adrenal or an ovarian mass that's secreting the estrogen. Menarche is the onset of the first menstruation. So your first menstruation or your first period, you are now considered menarche. That is the age that is the reproductive age. This is when you can ovulate and have a pregnancy. Then we get into postmenopause. So postmenopause is when the periods or your menstrual cycle stop for a period of months. And this again, we have to, for ultrasound, we have 2 very specific sets of postmenopause that we're looking at. So HRT in the elongated form is hormone replacement therapy. And what it does is it will give the patient injections or oral progesterone and estrogen to kind of decrease the side effects of menopause. So women who are going through menopause will have night sweats, hot flashes, mood swings. They may experience some dryness in the vaginal canal, and so giving them this hormone replacement therapy actually lessens the side effects of menopause for them. For ultrasound, it is going to change the architecture of what we're seeing. So when we don't have hormone replacement therapy and you are just going through menopause, we should see a decrease in size of the uterus. We should see a decrease in size of the ovaries. We should see a decrease in size of the cervix, and notice a little bit more dryness if we're doing a transvaginal. The key thing here is that the endometrium should measure less than 5 millimeters in a postmenopausal female without hormone replacement therapy. Now, when they are on hormone replacement therapy, we're going to notice that endo stays bigger for longer, and so it will actually be normal past 5 millimeters. and it needs to just measure less than 8 millimeters. We'll still see cysts on the ovaries because they're still being told that they need to ovulate. So we'll get these cysts on the ovaries, and as long as they're under 5 centimeters, they're usually benign, and we just follow them up. The other thing is because the ovaries are still being told that they have a job to do, they're not going to atrophy the way that a postmenopausal female without hormone replacement therapy. So you may see a 70-year-old woman who still has beautiful ovaries if she's still taking hormone replacement therapy. So this is a key concept or key question that we ask when we are doing these exams on a postmenopausal female. I also put in here this little chart for you guys, and it's just gonna kind of the normal endometrial thickness that you need to know for your boards. With our period, we're going to have cycles that happen in the body. One of them is going to be the endometrial cycle. And so we're going to stop here and kind of talk about the endometrial cycle. I'll point out a couple labs, but then we're going to tie it all back together because the ovaries also have a cycle that they follow. So the endometrial cycle starts day 1. This is the first day of the menstrual phase. This is when the bleeding starts, and what's happening is that those spiral arteries inside of the endometrium are starting to slough off. So we have these spiral arteries here, they're falling off and they're sloughing off some of this tissue with it. And so it starts at like 9.8 centimeters, and by the time we are done with the menstrual cycle on day 5, we have a very thin endometrium. Then we move into the proliferation phase. These are days 5 through 14, and as this happens, we're going to see a spike in that progesterone, and we're also going to see a thickening of the endometrium and a spike in estrogen. So this is known as the 3-line sign from day 5 to 14. It'll start at about 4 millimeters and end at about 10 millimeters. Once we get into this third phase here, this is the secretory phase. And this is when the uterus is really preparing for a baby. Remember that ovulation happens on day 14. So day 14, that egg is making its way into the fallopian tubes where it will be fertilized and then coming into the uterus. So these spiral arteries will get nice and strong and build up this endometrium all the way up to 1.4 centimeters. And we'll notice this by a hyperechoic center with a hypoechoic peripheral halo that will be thicker. We're going to take a look at this on the next slide here. So we have our first phase. We're going to be sloughing off that endometrium. You may see some fluid in here if the female is still on her period, but we're going to notice that it's a thin, echogenic linear line in the center of the uterus. And when we go to measure that, we are only measuring that echogenic line there. As we get into the proliferative phase, we'll start noticing some thickening. So this is going to be our late proliferative phase. We have a nice thick endometrium here, and we have that 3-line sign. We have a brighter line with this darkening, and then another bright line, and then some darkening, and another bright line. So this will be our 3-line sign for the proliferative phase. This is when our estrogen and our progesterone, our estrogen had a spike, our progesterone is slowly rising, and then we get into this secretory phase. We have had ovulation day 14, and our uterus is preparing a nice cozy bed for that egg. Our progesterone continues to rise in order to thicken that endometrium. It is going to be hyperechoic compared to the surrounding uterine tissue, and we're going to measure from outer to outer on this. At the same time, the ovarian cycle is happening. So the ovarian cycle and the endometrial cycle are both happening at the same time, okay? So day 1 through 14, we have that follicle stimulating hormone, and we're getting some follicles that are growing and growing and growing. We have our dominant Graafian follicle here that's going to grow up to be, almost 2.5 centimeters. And then day 14, we get that huge spike in luteinizing hormone. Remember that rupture is going to happen, and it's going to throw that egg right on out. And then as the luteinizing hormone and the follicle stimulating hormone decrease, we're going to be left with this corpus luteal cyst. That's going to be day 15 through 28. And what we're going to just watch that corpus luteal cyst, it will get smaller and smaller, and we might see some degenerative changes inside of it, and then it will disappear, and a new cyst will take its place and will start growing, restarting the cycle on day 1. Now, I talked about, we're going to have to watch our hormones and what they're doing on all of these days. So stay with me. If you don't understand this part, go back, draw it out yourself, see what's happening, so that way you can see each hormone doing what it's supposed to do in the space and the time that it's supposed to do it. So for your boards, breaking it down. Ready? Day 1 through 4, we have estrogen and progesterone levels are decreasing. And then day 5 through 7, our follicle stimulating hormone starts to develop that primary follicle. Between, day 7 and day 11, more follicles will begin to appear. Day 5 through 14, we'll have an increase now of estrogen during that follicular phase. And then day 6 through 13, we'll have that Graafian follicle nice and big due to that follicle stimulating hormone. Day 15 through 28, we're going to have progesterone levels increase while we're building that endometrium. We'll have a corpus luteal that's going to secrete more estrogen. And then if the egg is fertilized, that corpus luteum is going to flip and now start producing progesterone to hold that pregnancy until the placenta is formed, in which case it will then take over that job. If it is unfertilized, we'll see a decrease in progesterone and the corpus luteal cyst will degenerate. And we have that lovely picture here. So I'm just saying it all over again, okay? So we have estrogen and progesterone decreasing right here. We don't need as much, and so we're going to get a sloughing off of that endometrium. And then as progesterone and estrogen increase, we're going to notice a building up of that endometrium. At the same time, we see that follicle stimulating hormone going to work, and it's building this. But as the follicle stimulating hormone is decreasing, the luteinizing hormone is increasing until day 14, where we see a spike in both follicle stimulating hormone and luteinizing hormone, and then they will level back off. We'll still have a little bit, but not as much, and then the cycle will start all over again as it starts to increase, building those follicles. I also want to point out here, so we said, progesterone is increasing to build up this endometrium. Well, estrogen is increasing at the same time that the that the progesterone is increasing because of that corpus luteal cyst. So that corpus luteal cyst is responsible for this increase of estrogen, and the endometrium is going to be reflected in that increase of progesterone. So we solved the different phases of the endometrium, and we looked at proliferation phase and the 3-line sign. Well, in the same way, we're going to take a look at the ovary, because there are some cysts on the ovaries that are normal. We expect to see them depending on what phase a woman is in her menstrual cycle. So first and foremost, we have just a functional cyst. This functional cyst here is going to tell us that she is in fact releasing follicle stimulating hormone, and she is in those first 14 days of her menstrual cycle. Once we no longer see that functional cyst and we start getting this corpus luteal cyst, so you guys can see it here, this darker ring here, and if we put color on it, it's going to have a lot of color. It needed a lot of blood flow to do its job. Once this functional cyst is gone and replaced by this corpus luteal cyst, we may see some free fluid in the pelvis because some fluid was released. Once we get into, day 17, 18, 19, 25, that corpus luteum is going to be replaced by this corpus albicans cyst. And so that's just a regular cyst that we can't really see. It's just a little bit brighter. And we'll see that corpus albicans cyst there. The only time that it really becomes an issue is when we get these hemorrhagic cysts. And so what's happening here is that this functional cyst has grown so large without rupturing, possibly due to a luteinizing hormone deficiency or whatever the case may be, whatever caused it to not rupture, it is going to start bleeding on the inside because it has grown so large. And we will start to see these little echoes inside of the cyst. And this is considered a hemorrhagic cyst. So completely normal, we have a functional cyst. Also completely normal around day 14 of the menstrual cycle, and after we have a corpus luteum. Once we get into that later days of the menstrual cycle, we're going to get that corpus albicans, and then we always want to demonstrate these hemorrhagic cysts. This would not be a normal process of ovulating or menstruation. So something is not going right here. We're probably going to follow this cyst up. Other thing, we can't talk about the physiology of the female pelvis without talking about contraceptives, because contraceptives are used to stop the normal physiologic process from happening. And so we have a lot of different types of contraceptives that we are going to look at. So number one, oral. This is the pill. You take it every month. You have 3 weeks of hormones, and then you get 1 week of sugar pills just to keep you on track, right? So these pills will actually inhibit luteinizing hormone with estrogen and progesterone. So those little pills have estrogen and progesterone in them because the normal physiologic process says that when there is increased estrogen and progesterone, luteinizing hormone should decrease. And that stops ovulation altogether. And without that luteinizing hormone, there will be no rupture of that corpus luteum cyst, right? Okay, the next one is actually going to be an insert, and that's the fallopian tube inserts. Common name would be Assure. And so what they do is they take these copper coils and they insert them into the cornua of the uterus to scar up those fallopian tubes so that sperm cannot get from the uterus into the fallopian tubes to fertilize that egg. So this actually stops more so along the line fertilization and implantation because the egg can't get in and the sperm can't get out. So kind of does both. Then we have depomedroxyprogesterone acetate. This is a muscular injection. You get it every 3 months. Get right in your tush every 3 months, and this is going to stop you from ovulating by, again, affecting that follicle stimulating hormone and the luteinizing hormone. And it's also going to thicken the cervical mucus. So when sperm comes into the vaginal canal up through the cervix, a lot of them will die if there's too much mucus there because they cannot swim through it. And so when we have that extra cervical mucus, the sperm will die off before they ever even make it into the uterus. The next one is Nexplanon. This is a levonorgestrel implant. So this one goes into like the upper arm, into the muscle, under the skin, and it's going to use estrogen and progesterone to inhibit that luteinizing hormone and prevent ovulation. Then we have IUDs. These are very, very common. So these are what we call an intrauterine device. So what happens is the doctor, when you're on your period, and most of them prefer you to be on your period just to help it go in a little bit better. So while you're on your period, they will insert this T-shaped device into the fundus of the uterus that will kind of rest on the cornua where the fallopian tubes are coming in. And there's a couple different ones. So there's like a copper one that is non-hormonal that will prevent ovulation. And then there's a hormonal version that will use estrogen and progesterone to prevent ovulation as well. Finally, NuvaRing. It's a vaginal ring that sits up against the fornices of the cervix. It is a hyperechoic ring if we're looking on it on ultrasound. And it is going to, stop that ovulation from happening, that rupture of the cyst. It's going to thicken that vaginal mucus so that the sperm can't even make it to the cervix. And then it's going to make the uterus itself toxic to sperm. It's going to change the acid-base content of the uterus, which will kill off all of that sperm before they can make it into the fallopian tubes to fertilize that egg. And here are just a couple of our contraceptives here. So first we have the pill. You get your 3 weeks of estrogen and progesterone, and then you get your sugar pill. Here's those coils I was talking about. They get inserted into the cornua, into those fallopian tubes, and they're just going to wreak havoc in here and scar this all up so that it'll heal and nothing is getting in or out of there. I don't have anything for Depo. It really is just an injection into the muscle. So I don't have anything for that. But I do have a Nexplanon here. So this is where it's going to kind of sit in that upper arm. And then on ultrasound, we can actually see it here and here. So we have the muscle line here, right? And then just underneath that muscle line, we have that Depo implant. And this one's a really good one. So we have the muscle line, and then it goes right into the muscle in that upper arm. Then we have the IUD. This is a big one. We are very familiar with identifying IUDs. If you're doing a pelvic ultrasound and you see an IUD, you need to check placement. It is a part of most protocols, and you may just get a patient who says, they couldn't feel the string anymore, and the doctor wants to check placement. So what we're going to do is we're going to, in sagittal, see this hyperechoic line, and it needs to be up in the endometrium, up in that fundal portion, up past the cornua, right? And then in transverse, we're going to get a bright line, a dot, and a bright line, almost like a T, because that is what we are seeing here. Bright line, dot, bright line when we're scanning. And then in long, we're seeing this bright line here. So here it sits, there's the cervix, it sits up in that fundus portion of the uterus, and there'll be a little string that they can feel. And if they're not feeling that string, then they'll come in for a placement because these can sometimes puncture the uterine wall, and they'll come out of the uterus or out of the endometrium. So we're checking for placement. And then finally we have the NuvaRing. So Here's your vaginal canal. These are fornices on either side of the cervix, and it just kind of sits right in there. So that is all we have on the physiology of the female pelvis. If you guys have any questions, bring them to class. We're going to move right into pathology next.